Thank you for joining us for today's webinar. This is Medical Management of Behavioral Health Issues Related to All Levels of TBI. Now, this webinar is sponsored by the Rural Veterans Health Access Program and jointly provided by the Alaska Nurses Association and the Alaska AHEX, Area Health Education Centers. There is no conflict of interest to be disclosed for any planner or presenter. Now, the Rural Veterans Health Access Program is a federally grant-funded project for the Alaska Department of Health and Social Services, Division of Public Health. The objective of the program is to increase access to health care for veterans in Southeast Alaska through the deployment of a telehealth network. It also provides training to both behavioral and medical health professionals on the delivery of telehealth services using the available technology. Now, Alaska has a higher rate of TBI than the national average and was identified as a focus area for the program. It provides training to agencies and community health providers to care for veterans, as well as other rural community members. If you would like additional information on the Rural Veterans Health Access Program, you can find it on the project website or by contacting the program director, Susan Maley. Now, our speaker today is Dr. Amy Murphy. Dr. Murphy is a board certified in brain injury medicine, physical medicine, and rehabilitation. She has partnered in the development of practice guidelines for brain injury treatment and is currently a consultant for Providence Medical Center. We would like to welcome Dr. Murphy.
Okay, so today we're going to discuss behavioral health issues that can occur after traumatic brain injury. And I'm just going to jump right into the objectives. We're going to talk about definitions. First of all, what constitutes a traumatic brain injury, and what are we looking at when we're determining whether it is a mild, moderate, or severe injury. We're going to discuss assessment as well as symptoms, focusing on behavioral health symptoms that can occur after brain injury, treatment, as well as have time for discussion and questions. Now, I do want to mention on the treatment point, I do have some slides here that cover some various medications, and typically I go really into depth for medication management for when we give this to providers. However, I also think it's important from a family standpoint and a patient standpoint to be able to look and recognize some of the key medications that are both highly recommended after brain injury as well as those to avoid. So we are going to have them in the presentation. However, they're not part of the handout that you have available for download, but all of the other slides remain exactly the same. So the National Brain Injury Association defines TBI, traumatic brain injury, as an insult to the brain that is neither congenital nor degenerative in nature. It's very important to realize that impairments can be either temporary or permanent and cause partial or total functional disability or psychosocial impairment, and that is regardless of the severity of traumatic brain injury. A mild traumatic brain injury has to have just one of the following. So LOC stands for loss of consciousness. And if it would occur, it would be less than 30 minutes. Anything greater would be a higher level brain injury. GCS is Glasgow Coma score. And typically, well, 15 is a normal score, so 13 or 15. Anything lower than that would, again, be a higher level brain injury. And PTA is post-traumatic amnesia. When this should occur, it would be less than 24 hours. So I've given lectures on mild traumatic brain injury in the past, and it's important to note that you do not need a loss of consciousness in order to have a diagnosis of mild traumatic brain injury. You only need one of the following criteria, and often people can have an alteration in consciousness that, even if it occurs briefly, still would fall under the heading of post-traumatic amnesia, and so therefore they would be diagnosed with mild traumatic brain injury, which is also commonly called concussion. A moderate traumatic brain injury has a loss of consciousness greater than 30 minutes but less than 24 hours, with a Glasgow Coma score of 9 to 12, and post-traumatic amnesia occurring greater than 24 hours but less than 1 week. And a severe would have loss of consciousness greater than 24 hours, Glasgow Coma score of 8 or less, and post-traumatic amnesia greater than 1 week. The other thing that is important to note is that you scale and score the brain injury based on the worst symptom. So for instance, if somebody had a loss of consciousness that was very brief, say for instance for 5 minutes, a Glasgow Coma score of 15, however their post-traumatic amnesia lasted for greater than 24 hours, then you would be, but say for instance less than 1 week, you would be looking at a moderate traumatic brain injury because the worst symptom, the one that lasted the longest, was the post-traumatic amnesia, so you score for that one. It's also important to note what post-traumatic amnesia is and what it isn't. So post-traumatic amnesia typically lasts for a set period of time, and you know when someone is out of post-traumatic amnesia because they're able to start recording memory. So typically we will go back and we will ask somebody, what is the first thing you remember after the injury? There are often times that people are awake and interacting with emergency personnel, but they don't remember those initial moments. And oftentimes we'll talk about remembering, oh, well, my first memory was in the ER or on the drive home. Now, it is very common also to have periods surrounding the accident that you don't remember and may never get back, but that still doesn't lengthen the period of post-traumatic amnesia, as well as having occasional memory loss or inability to remember certain things throughout the day. That also is not post-traumatic amnesia because you're able to remember other things. This is really, it's a state of consciousness that's decreased because you are unable to form any new memories, and you consistently have to be reminded about what's going on around you, what the date is, and so forth. So post-traumatic amnesia is oftentimes used to determine the severity of brain injury. And other times it can be very difficult, especially in cases of severe traumatic brain injury, to determine exactly how long that may be if somebody has to be artificially sedated due to other injuries. So we make our best estimate on the injuries that they've sustained. It's important to note that psychological manifestations or mood symptoms can occur with all levels of traumatic brain injury: mild, moderate, and severe. Some symptoms are more common with severe TBIs. Some symptoms are more common with mild TBIs. However, there's not a golden rule that separates the two, and you can have crossover between groups. Symptoms after traumatic brain injury definitely require more thought for any underlying process prior to just starting treatment to take care of the symptoms. For assessment, symptoms are commonly misunderstood and mismanaged. Common scenarios post-brain injury that can occur if somebody has mood symptoms that arise are as follows. Sometimes these are a completely new onset of symptoms. Someone who's never had issues with any feelings of depression, anxiety, or other symptoms, they've had a brain injury and now they have completely new symptoms which have never occurred. Sometimes you can get a worsening of traits that now require treatment. So someone who may have had anxiety in the past or may have had some issues with depressed mood but never really required treatment, now post-brain injury require treatment for those symptoms because they're worsened and they're decreasing their ability to function. You can also have a third group that have had well-managed symptoms that are now no longer managed on their current medications. So someone who had had a history of depression or a history of anxiety or bipolar disorder that were doing very well on their medications, they've had a traumatic brain injury, and now those medications are no longer covering their symptoms. Occasionally you can have a complete shift in the previous symptoms. So somebody who had more depressive symptoms prior to their TBI are now having more anxiety. Or somebody with bipolar disorder who was primarily manic now is having more issues with depressive symptoms. It is rare that you get resolution of previous symptoms post-traumatic brain injury, but occasionally we can see that in people with schizophrenia, depending on the area of the bleed in the brain. But more often than not, what we tend to see is either new symptoms or worsening of symptoms or traits post-traumatic brain injury. And the treatment rules and the treatment guidelines that are used to take care of things such as depression, anxiety, bipolar disorder that are not due to TBI are different than those that we use post-TBI. So we'll cover a little bit of that here shortly. For assessment, a complete history is very important. We definitely want to look at a few things. Number one is how many brain injuries had been sustained in the past. And many times people don't have a diagnosis of a brain injury because, say, for instance, they had a concussion without a loss of consciousness, and so therefore their provider never gave them the diagnosis. So it's very important to give a full history of any head injuries that occurred in the past so that the provider can then find out how many have occurred, because that definitely does change the risk for different symptoms to come up later. Previous behavioral health history, as we discussed before, to determine if there were traits or any symptoms that had been managed previously and how they're doing on the medications that they had been on previously. And then other risk factors, especially trauma. Even if someone has not had any injuries or blows to the head, we do know that sustained trauma, like childhood trauma, childhood abuse, does create changes in the brain that look very similar to brain injury. And so somebody coming in with their first concussion, but with a history of sustained abuse, will look more like someone who's had multiple concussions rather than just their first. A full exam done by the provider to look at both the neurologic symptom system as well as mental status exam, looking at mood, how well you're able to interact and relate with different providers, is very important. They should be looking at laboratory studies, any radiologic studies or MRI, CT scans of the brain. Cognitive function, which is very important and definitely weighs in on mood. From a standpoint of somebody with a severe injury who is agitated because they're not able to retain memories, they're still in post-traumatic amnesia, to somebody with a mild injury who can have what we call input overload and get feelings from anxiety because their cognition is slowed. And you also want to look and see, were there any other physical injuries that occurred? Does this person have, multiple broken bones? Do they have weakness on one side or other neurologic symptoms that would be making it harder for them to heal? So we're going to move into symptoms, and the first symptoms I have listed are the ones that are typically of most concern to patients and their families. And we'll start with agitation. Agitation is actually something we expect because that is a healing phase of brain injury. When someone is in post-traumatic amnesia, it means they're unable to record and maintain any memories. So this will lead to an agitated state, which is typically a very confused state. But this is the beginnings of recovery, and people typically can come out of that relatively easily as they heal from their brain injury. Aggression, however, usually is occurring as post-traumatic amnesia is wearing off and the person is regaining awareness, and it's of greater concern for multiple reasons. Number one, it is more difficult to treat. It's definitely a concern for safety for the person who is having the aggressive behavior because sometimes that's directed toward themselves. It's also a great concern for family members or for other staff that are in the hospital, or even if they're in a long-term care facility, staff that would be working there. And these symptoms tend to be more long-term, unlike agitation, which will resolve within the early phases of recovery. Aggression can tend to stick around. And so it's very important to recognize this early and start looking for the reasons underlying it and possibly treatment. For mood, you're going to look at prominent symptoms. Are these depressive type symptoms that are occurring? Anxiety type symptoms? Are there panic attacks co-occurring with the anxiety symptoms? Any symptoms of mania or bipolar type symptoms? PTSD or stress response symptoms. And it's important to note that you can have these symptoms not just on the event that occurred that created the head injury, but oftentimes we will have people that had previous trauma that were able to work through the trauma and were doing very well, but now because they've had an injury to a particular part of their brain, they no longer have the same coping mechanisms and can have some of the stress responses come back up again over something that may have happened years previous. Hallucinations also can occur after traumatic brain injury due to a variety of different reasons. And then unsafe behaviors and impulsivity typically come from a lack of insight. And it is very common after traumatic brain injury, especially in the early phases, for people to not be aware of the deficits that they have, and so they will engage in behaviors that are risky because they're not aware that they shouldn't engage in them. The biggest example I can give of this is driving. We will typically tell someone after traumatic brain injury that they should not drive because they are not safe to drive until cleared by therapy and physician. And yet, because they lack the insight to understand why they can't drive with their head injury, they may try to go out and do that. And again, it's not an aggressive type behavior, it's simply unsafe behavior due to the lack of insight. Sometimes you can have personality disorders that will arise, especially if there were traits of that personality disorder previous to the brain injury. And it can be very difficult for families because it can sometimes feel that there's a brand new person living with them that they just don't know. And so for that reason, as well as just the trauma of having to, work with and support someone who is a brain injury survivor, I recommend also that there be supports in place for family and caregivers as well. Looking at substance abuse, especially the frequency, and to try to figure out if the person is using the substances to try to help with self-medication for whatever symptoms have come up. Psychosocial issues and stressors are very important to discuss because, no one ever plans on having a brain injury. No one ever plans on not being able to work. And so there's a very large difference between somebody who is single and was basically providing their own care through their own finances and now are unable to work versus somebody who has perhaps a large family that has other income that has come into the home that has more financial support. Legal issues and stressors can also work on delaying healing and increasing psychological symptoms. You have to find out if there are any charges pending, either for the person with the brain injury or for the person who may have, been the responsible party for the brain injury. As well as looking at any competency issues and making sure that there are people that are available to support the brain injury survivors in making sound medical and legal and financial decisions post-injury. Other considerations that we look at prior to starting treatment for mood. There are many things that can manifest as mood symptoms after brain injury, and you have to look at these things first and treat them first before just adding on medications on top of it, because it will definitely cloud the issue. So metabolic refers to anyone that may have had any liver or kidney issues, and they may have done just well with them in the past prior to their brain injury, but now since the brain is more delicate and not as resilient, they have symptoms that occur due to their kidneys or their liver not functioning as well as it could. Alcohol or drug withdrawal or use or toxicity can also create a variety of different symptoms. And this can even occur not just with illicit drugs, but also prescription drugs, because more often than not, people after traumatic brain injury will respond differently to different drug classes. So it's important to be aware of that. So if there's something new that is popping up, the the first thing you want to look at is to see if there were any new medications that were put on board that could be explaining the new behavior. Another big thing is infection or a systemic process. So for instance, urinary tract infections can cause a great deal of change both in mood as well as behavior in somebody with a traumatic brain injury. So if you have someone who is doing well and now has something new that has popped up, you would want to look at both medications as well as possibility for infection. Seizure disorders can cause a variety of different symptoms, from hallucinations to increased irritability to agitation. So it's very important to make sure that that is being monitored closely and testing is done and treatment is provided if it's seizures. Endocrine dysfunction is also very important after brain injury. The thyroid function can decrease often, and it's recommended to replace thyroid hormone for those who are low or even borderline with symptoms. Also, testosterone levels should be checked both in males and females and replaced if low or borderline with symptoms. Cognition, as we mentioned previously, can cause a variety of symptoms, from fatigue, which can mask itself as depressive type symptoms, to input overload, which often masks itself as an anxiety disorder. And so treating the cognition first will actually help resolve those symptoms. Headaches, especially migraine headaches, can have a variety of behavioral symptoms, as well as sleep disorders, including REM sleep disorders, as well as just the inability to start or maintain sleep. So for treatment, the first thing we typically do is we look for any medications or substance abuse that can worsen symptoms. And at this point, I just want to point out that alcohol is one of the main substances we know that will delay healing after traumatic brain injury. So any alcohol use should be avoided unless otherwise noted by a provider. If somebody's currently using alcohol, especially on a frequent basis, they may require somebody to help intervene because that is something that needs to be weaned. It cannot just be stopped because it can be fatal if you stop using alcohol if you're using it regularly without any additional supports. If there are no medications or no substance abuse that could possibly be worsening the symptoms, then we look at some of the things we talked about previously, especially issues that would cover a variety of different symptoms, and we treat those first. So sleep, making sure that adequate sleep is maintained, making sure there are no REM sleep disorders, also making sure there's no sleep apnea, because there's a very high rate of sleep apnea after traumatic brain injury. Oftentimes, just taking care of sleep will help resolve a multitude of symptoms. The same with seizures, migraines, and then again, if you have someone who may be presenting with agitation, ensuring that there's no infection or any metabolic process that could be creating this delirium, which is actually something that could be treated for the underlying condition rather than with medications pushing toward agitation. And then to look for endocrine, especially testosterone, because we do know that if somebody has low testosterone after traumatic brain injury, there tends to be more issues with agitation and aggression, which will resolve with treatment. If you've taken care of all of the things that we mentioned previously and you've looked at any underlying process that could have been contributing, and there are still symptoms that remain, typically we will start by trying to treat cognition first, unless the mood is completely overwhelming. So if there are concerns for suicidal or homicidal ideas, if there are concerns that you just cannot get somebody out of the house, concerns for safety for the patient or for family members or staff, those are things that would have us starting treatment sooner rather than later for the mood. However, unless that is the case, we try to treat cognition first, because most of the time, if we don't resolve all of the symptoms, we can at least resolve a majority of the symptoms and find out what is left. Once we do that and we see exactly what is left as far as mood symptoms, it's important to understand that mood disorders after a head injury respond very differently than primary mood disorders. And let me explain what I mean by that. So somebody who has depression, who has no history of head injury, will typically be started on a certain class of medications that work very well for depression. However, depressive symptoms after traumatic brain injury actually can respond a little bit better to a different class of medications. So there are certain things that work better than others after a head injury. And if somebody's having hallucinations, it's just good to remember that it's not typical psychosis. So many times if there are medications brought on board to try to manage the hallucinations, they don't cover things as well. So you definitely want to make sure to talk to your provider about looking at other things that could be causing hallucinations and make sure that those are treated first, such as seizures or sleep disorders. And then if hallucinations remain, just to understand that it may require a lot more, education as far as just reorienting to what is real, what is not real, because in many cases the medications will not cover the hallucinations entirely. We try to use non-medication management as much as possible. So in the case of somebody who has increased agitation or aggression, as well as issues with input overload, we try to make sure to do some environmental changes. Also for sleep, making sure there's adequate exposure to sunlight during the day so that the body can be aware of what is day and what is night. Making sure there's reduced noise and distractions at night. Keeping any background noise to a minimum. Making sure that there aren't too many conversations or too much input coming in from the environment at any given time. All of this will help the brain to rest and heal. If there are medicines that have a side effect of keeping people awake, making sure that those are given early. And likewise, if there are medications that have a side effect of sleepiness, making sure that those are given later. Providing education to family, to the brain injury survivor as well as to staff is also very important so that they're aware and can keep up these environmental changes as well. Other than physical therapy, occupational therapy, and speech therapy, the fourth therapy that I will typically recommend to is either neurofeedback or EMDR. Both of these are counseling interventions that work in many ways like a therapy. Neurofeedback and EMDR work within the principle of neuroplasticity and can actually help with both cognition and mood. Both of them can also help with sleep in different ways. And what they do is they work on the inner portion of the brain with helping to decrease feedback loops that can sometimes come up after traumatic brain injury that keep people stuck in particular behaviors. Supportive counseling is also of benefit, especially if there was a lot of trauma surrounding the incident. Also supportive counseling for anybody who's a caregiver. And then neuropsychology for both testing as well as for continued follow-up. All of these are very important. If everything has been maximized in the environment as well as with different therapies and there are needs for medications, we try to use medications that cover multiple symptoms to try to keep the list short, knowing that different medications can interact with each other and cause a variety of different symptoms in somebody post-brain injury, as well as to keep it short simply because most people don't enjoy taking a multitude of medications. And so as we go through these lists for medications, what I'm going to do are point out some common medications that are both offenders, things that can cause symptoms to come up, as well as medications that we like to use to help with symptoms. And so while I realize this is a lecture for, brain injury survivors, families, and friends, sometimes it's good just to have an awareness of what is on the medication list so that you can keep a second eye out. So first we're going to talk about the treatment for seizures because there are a couple important things to note. The first medication listed at the top is also known as Keppra, and so you will often see this on somebody's medication list if they have had seizures post-traumatic brain injury or even previous to their brain injury. And this is a medication that works very well for managing seizures. However, it's also important to note that this is a medication that does have a lot of side effect when it comes to increased irritability and agitation. And if that is the case, if you are on this, if you have a loved one or if you yourself are on this medication and you've noticed those symptoms, please be aware that, while this is an important medication and you absolutely should be taking it for your seizures, there are other medications that can also be placed on board to help decrease the irritability for the one that is protecting you from seizures. And that's typically the second medicine, which is also known as Depakote. And it can be given in lower doses, not necessarily seizure doses, to help with the irritability, which is good because at higher doses to treat seizures, this medication can be slightly sedating. So you can have a good combination of the two. Phenytoin or Dilantin is another medication that can be used for seizures. So if you have someone or you know someone who is on Keppra and absolutely is not able to manage the symptoms of agitation with the Keppra on board, this is a medication that has been around for quite some time and can manage seizures, and it does not have that side effect. So that would be, a discussion to have with your physician. Headaches. Topiramate or Topamax, which is listed as the top, is one of the most commonly used medications for migraine prevention in the United States. However, it has a very high rate of side effect for cognition. Even at lower doses, I've had many people complain that they've been unable to think, unable to speak with it. I've had people that have had side effects so badly with it that they thought they were having a stroke because they were unable to get any speech out whatsoever. There are other medications that definitely can help with migraine prevention. Again, Depakote is on that list. This is a great medication to help with both migraine prevention as well as anxiety or increased irritability. And then, of course, there's Butterbur, which can help with migraine prevention, and it does not cause any of the above side effects. It's an herbal supplement. It's very important to use the correct brand of this herbal supplement, so definitely do not start this supplement without discussing it with your physician first, because in the United States we do not monitor our herbal supplements as they do in the European Union, and so there are some supplements that are available here that have not been standardized and can be at risk, especially for liver failure. So it is very important, even though this is an herbal supplement, that you discuss the use with your provider, because they can guide you toward the appropriate brands. Amitriptyline is a medication that we will sometimes use for both tension-type headaches as well as to help with sleep. It's important to note that this is a medication that we give in low doses. We typically do not use it in the doses required for the treatment of depression, because it is a medication that can be overdosed on. And so low doses of amitriptyline can be very effective both for sleep as well as for tension-type headaches. And I have this list on basically Tylenol, aspirin, and Advil, because these are all medications that work very well in getting rid of a headache when it comes on. And it's important to note the absence of opiates, because really there is no role for the use of things like Percocet, Fioricet, oxycodone for use in headache alone. And these are medications that can be very cognitively sedating and cause confusion, and so unless there are other reasons to be on that medication class, I recommend avoiding them. And triptans are another medication that can be used to help with getting rid of migraine headaches. And again, there's no cognitive sedation with these. Cognition, as we had discussed previously, it's important to treat cognition if there are any issues, because you can help with things such as the anxiety for input overload. It can help reduce fatigue, help improve short-term memory and processing speed, and all of these can combine to actually help reduce the symptoms that of both depression as well as anxiety if they were secondary to cognitive decrease. And most commonly, we use the second medication listed called amantadine. This is a medication that works extremely well after all levels of brain injury. It can help with agitation because it helps somebody move through the healing process more quickly so they're not in post-traumatic amnesia for as long. And it also works very well for people with milder injuries because, again, it will help with processing speed, so it reduces input overload, decreasing their anxiety. And it also helps with improving fatigue, so they're able to get out and work on their endurance. And oftentimes, fatigue-based symptoms can mask themselves as depressive-type symptoms. For agitation and aggression, I think it's very important for you all to know that this, especially with providers, we've talked about the use of antipsychotic medications for aggression and how we really are trying to decrease the need for these. Antipsychotic medications sometimes have to be used in periods where you are really concerned for safety, but the prime focus should be on medications that keep the occurrence low. So if these medications need to be used, they should be used very sparingly. And the last medication on this list, lorazepam, belongs to a class of medication called benzodiazepines. Earlier when I mentioned that alcohol will delay brain healing and stop the brain from healing after traumatic brain injury, this is the other substance that also will do so. So it is recommended that this medication should not be on anyone's list other than those that have a seizure disorder, because this is used as needed to break seizures when they occur. So this is if there's somebody that has a history of anxiety and is on this class of medications, we always recommend slowly weaning them off and starting other medications for anxiety, as this does decrease healing after brain injury. We recommend, again, more medications from the anti-epileptic class, especially the top one, which is Depakote, because this can help with anxiety and reduce the need for as-needed medications. For mood, as we discussed previously, SSRIs, or selective serotonin reuptake inhibitors, are commonly used for people who have depressed mood. However, after brain injury, we often will recommend duloxetine or Cymbalta, which is a medication from the serotonin norepinephrine reuptake inhibitor class. The reason we do this is because this medication helps on a variety of different levels. It can help with depressive type symptoms. It can help with pain. Because it also works with dopamine, it can help if somebody's also taking amantadine on improving their cognition, so they can actually think better with it. And since it also has the norepinephrine piece, it can help with what we can see after brain injury, which is, people having an inability to control their sympathetic and parasympathetic response. So their rest and digest versus fight or flight. So if you have somebody that that's having a lot of fight or flight responses when they don't need to, and they recognize that, this medication can actually help cover that a little bit more effectively than the other medications, such as Zoloft and Prozac. Out of that class, Cymbalta is really the only one I recommend. Effexor works to a lesser extent, and I do not recommend Wellbutrin at all because it decreases seizure threshold. And I've seen quite a few people come in that have had seizures erupt because they were started on Wellbutrin. Again, for anxiety purposes, Depakote is one of the medications you can use to help reduce anxiety. You can schedule that. Sometimes gabapentin or Neurontin will work as well, but more often than not, unless somebody is very sensitive to medications, it is just not as effective. And the other medication, which is listed at the bottom here, is buspirone or Buspar, which is a non-benzodiazepine medication that can be used for anxiety disorder and scheduled. And the goal is to keep the anxiety low enough so that you don't need as-needed medications. Lorazepam, again, the benzodiazepine, we avoid. And instead, we will work with a medication called tizanidine, which is a muscle relaxant and can be used as needed to help with anxiety symptoms. And it does not delay healing in the brain. So in summary, behavioral symptoms are common after all levels of brain injury. And really, understanding the root of the problem is key. So before any medications are even considered, there should be a thorough understanding of what is going on with the brain injury survivor, with their family. What are stressors? Are there any physical things underlying it that need to be treated first? You want to maximize therapies. You want to improve the environment, make sure that you are doing everything to promote the brain and healing, and provide education for the brain injury survivor, for family, for staff. You want to make sure that you are aware of the things that are out there, the things to avoid, and the things that are beneficial. And if medications do need to be used, then medications should be chosen with collaboration from both the brain injury survivor and their family on looking at what medications will be best to help cover multiple areas and multiple symptoms that they may be experiencing. So that is the end of the presentation. If there are any questions, I would be happy to answer them. And thank you very much for joining us on the call.
We do have one question right now. What do you recommend for patients to bring to a provider's office if the provider wants to become more educated?
So it's very important as far as just from a personal standpoint to make sure that they have access to all of your records. So if you have any laboratory studies, especially if you had anything to check your kidney function, your liver function, if you had any previous lab studies that looked at your thyroid or your testosterone levels, any images of the head, any images of the neck or the back if there were other injuries. Those are all very important to take, as well as keeping a good running list either in a journal or on your phone, however you want to do it, of medications that had been used in the past and and how you responded to them. That is crucial for understanding things that have worked and things that have not worked so that they don't have to reinvent the wheel. Now, as far as just general education on brain injury for providers, some of the best resources we have actually are through the VA. They have quite a bit of their stuff online, including diagrams listing, what treatments should be brought in at what points after head injury. And there are a lot of handouts on sleep, mood, and so forth, vision disorders, basically anything you could possibly think of. They have little downloadable PDF files that could be used by providers, printed out, or just kept on the computer. So those are some general resources that are available. And then, of course, making sure that you have all of your information in place so that they're aware of things that have been done in the past, what you're currently on, and then just trying to keep a good journal of symptoms and things that are currently a problem for you. Okay. There are a couple of things that I wanted to mention that as I was giving this lecture this morning, I realized had gotten left off, and one of those is also just to mention that in PTSD there is often complaints of nightmares. We actually do have good medication to use for nightmares, either with or without PTSD. And that's called prazosin, which is another blood pressure medication that specifically just works very well for nightmares. So I wanted to put that out there as well because I had not listed it on the slides, but it is a medication that you may see on the list. It's something we use very commonly both in the VA as well as in the Department of Defense and hospitals working with veterans and active duty members with both TBI and PTSD.
Okay, we have one more question. Are you familiar with the neuroenteric axis, the neuroenteric axis, the link between brain injury and the gut?
So there's a lot of information going on about the neuroenteric axis, and for right now, just as for the neuroendocrine axis, we have a lot more questions than we have answers. And so I've talked a lot with patients about some dietary changes that they've had with good benefit, especially reducing inflammatory foods just to promote better gut health, and doing so improving mood and cognitive health. And so we don't have anything set in stone as far as recommendations for one diet over another in regards to that, just as we have very limited information for the neuroendocrine system other than looking at thyroid and testosterone, even though we know there are a variety of hormones that come into play and can be altered after traumatic brain injury. So as that information comes out, we'll be putting more out there, but I always recommend to anyone who comes into my office to definitely start by at least trying to reduce inflammatory foods, and then from there, just one food, one thing at a time to determine what works and what doesn't work. We have a few more minutes, and I had brought up the idea of using prazosin for nightmares, which is something that I wanted to make sure to add in. And the other piece is just, kind of putting out there that, I have a lot of pet peeves that come into play with stories that I hear from brain injury survivors and their families. And I just want to kind of reiterate to take heart, because in my mind, somebody coming in who has done their own research and is a well-educated person trying to come in and be an active part of their own health care, that to me is, a great thing and something that you should be happy to come in with your provider, and definitely to remain educated and be aware of the things that are out there. And don't be afraid to come in with that knowledge, because it's very important. It's an interchange. It's between both you and your physician. So this is a working relationship. It is definitely not one-sided.
We have one more question. What do you tell the general public to understand TBI? Is it a syndrome, an illness, a disease, or something else?
So really it's quite a few different things, because the injury itself is an event. And so you have the initial event that created the injury. And then what occurs after that, I don't necessarily think of it as a syndrome as much as I think of it more, we use the term sequelae, which basically means any of the aftermath that may or may not be present after a traumatic brain injury. Because really, once you've had a traumatic brain injury, you've always had a traumatic brain injury. I likened it earlier today to, once you have been pregnant, you have always had a pregnancy even after you have the child. So if somebody's asking you on your history, have you ever been pregnant, you don't discount it simply because you've had the baby. It's the same thing with a traumatic brain injury. Even if you've fully resolved from the symptoms, you've always had it. There's a memory in your body of it being there. And it's definitely much more than just the way the brain acts. There are also structural changes that we know that take place. So as far as kind of how to label it versus a disease, a syndrome and so forth, I don't necessarily think of it in that way, because it's just so all-encompassing that really it's a life-changing event. And so I don't think any of those words really describes what you're living with after it's said and done. Well, and while we're waiting, I'll just kind of throw out what is what is a typical scenario that I look at and what I see commonly that occurs, especially after mild traumatic brain injury, which is something that we see much more commonly than moderate and severe as far as numbers. So typically when somebody comes in after mild traumatic brain injury, again, I will look for any type of underlying substance abuse, underlying medical issues that could be occurring and explaining some of the symptoms that they're having. More often than not, that also includes just going over their medication list and making sure they're not on a benzodiazepine, making sure they're not using alcohol. And then from there, we will go into trying different therapies, trying different environmental things. But more often than not, I'm really quick to jump on trying for treatment for cognition. And if there's one thing from the entire lecture series that I would put out, it's that you can decrease a lot of the psychological manifestations that you see after brain injury by simply treating cognition. And that also occurs for the moderate and severe level, because if you treat cognition, we have just excellent, excellent data to back up that it will help somebody progress through the levels of healing more quickly, more efficiently, and you will see less agitation and aggression on the inpatient unit. So it's important to get that started early.
We have one question. Does the professor have any recommendations for physicians in Alaska or West Coast who specialize in TBI resulting from post-concussion syndrome?
So post-concussion syndrome is something that is very important, and this is one of the reasons why we're trying to really focus on treatment early. So we know that the incidence of post-concussion syndrome is much higher than we had originally reported, 20, 30 years ago. And so we realize that this is a problem. There are a lot of different studies that are occurring in Europe to try to determine, how can we figure out who the at-risk population would be that is going to develop these symptoms versus somebody who's just going to spontaneously recover. And so from that standpoint, we are putting recommendations in place. We should have them at least available through Providence by this fall, where we will have the guidelines for identifying when a mild traumatic brain injury occurs, when a concussion occurs, administering a questionnaire, which is the Rivermead, to determine if they are at risk for developing post-concussion syndrome. And those that are at risk should definitely get started with higher level treatment earlier to ensure that they have better outcomes. And of course, looking at the risk factors, especially history of number of head injuries. So we are working on that, and that is a work in progress, especially as we're getting more and more of the research in to see exactly what the numbers are.
What kind of return to work guidelines would you recommend, especially when people with mild TBI are denied disability in Alaska? This will be our final.
Yeah, that's a huge problem, especially if we're looking at workman's comp. And so, you have the clinical piece, which is, our recommendations for return to work are when work no longer puts their symptoms to such a place where it incapacitates them. So for instance, if I have somebody coming in and they're having headaches, if they're having difficulties with fatigue, we do a return to work program that's similar to a return to play program for sports, where we get them involved with therapies, work on their fatigue, work on their endurance, and then medically co-manage any symptoms to get them back as quickly as possible. Now you get different, workman's comp or different types of claims that can get in the way of that and actually delay healing, and we know that occurs. And so from that standpoint, you simply work with the family and you do the best that you can, because from a common sense standpoint, people have to work. You have to make money to live. And so I just do my best at that point to get them on board and healed as quickly as possible, which is why many times in that case, yes, I stressed, starting with environmental things and therapies first, but sometimes I will also start earlier with medication management just so that we can get them through the healing process more quickly. because we know that it's going to be a race against time to get them back.
Is the mechanism of injury a determinate severity of nature of the symptomology, i.e. is the MVA versus blast trauma versus sports concussion versus assault? If the emotional content of the injury a factor in the treatment and ability?
Absolutely. And you've hit a wide variety there on the head. Blast injuries are an entity unto themselves. And so, without getting into too much depth, just understanding that the mechanism of blast creates different changes within the brain than, say, for instance, somebody with the same level of injury, say, two people with mild traumatic brain injury. It's very different in the way that it affects the brain between a blast injury and, say, an NVA. So you're going to have different manifestations that occur, especially when you're looking at somebody that's been in theater and has probably been through a high stress response from their work within the military versus somebody who's been in an automobile accident. So absolutely it can create different treatment paradigms. And so you look at that and you take all of that into consideration. Sports concussion, same thing. We know that chronic traumatic encephalopathy is out there, again, working on treatment. However, when you look at the baseline, which is why I brought it from a symptom standpoint, keeping in mind the symptoms in the middle of the story will help you to understand the best way to kind of get that first piece in for treatment.
We do wish to thank Dr. Murphy today and all of you for joining us.